So hello and welcome to another episode of Bullhorns and Sirens, and this is episode 8 with me, Tommy.
Me, Sam.
So yeah, hello. We'd also like to really thank everyone for your support buying the ECG book and the student paramedic book. We're really sort of surprised with the amount of support and the amount of people.
Oh, massively overwhelmed. Yeah,
Yeah.
absolutely. We're so grateful for everyone's sort of reviews and thoughts, and yeah, thank you very much for your support, guys.
Yeah, cheers. But we're not here to talk about that, are we, Sam?
Not at all. No.
So we have got an amazing guest, and we're extremely lucky to be given the precious time of Dr Fionna Moore. So many people have been getting in touch with us, telling us how excited they are to listen to the episode, and we've got a good hour or so of jam-packed, amazing content. We're going to be asking Fionna about her career, the move into urgent care, about HEMS, and so much more. So please give a very warm welcome to the incomparable Dr Fionna Moore.
I was going to say, we can probably get James to add a clapping soundtrack there.
Yeah.
Rather just do bravo.
I mean, there's two people, but hopefully there's a big audience, Fionna. So, yeah. We've got about 5 people listening at the moment. So, but yeah, thanks so much for giving us your time. We really appreciate it. Would you mind introducing yourself, telling us a bit about the journey from becoming a doctor to then moving into the different roles you worked in with the ambulance service?
Yeah, of course. Thanks, Tommy, and thanks to you and Sam for inviting me along and for the completely unreasonable build-up. But I guess in terms of my career, I'd always wanted to do medicine, apart from a brief flirtation with trying to join the RAF when I was about 11. But at that stage, women weren't considered as potential pilots, so I reverted to medicine and went into medicine, qualified at UCH in London, and initially my career was going to be down a surgical route, but it was at that time really quite difficult to do surgery part-time in a reasonable time frame and have a family. So emergency medicine was just coming on the horizon then, so I was one of the early senior registrars in emergency medicine, and I worked for a phenomenal guy called Brian Galbally, who was a consultant at Ealing Hospital.
Oh, okay.
And he had been an intensivist at St Vincent's in Melbourne and came to this country because he loved the theatre and musicals, but he was also an extremely wise physician, and I learned a huge amount from him. And then I went to UCH as a consultant. I worked there for 9 years. Subsequently went to the John Radcliffe in Oxford. Couldn't persuade the family to move, so came back to London, worked at Charing Cross with another absolute icon of emergency medicine, Hugh Millington, who is still working there, working in urgent care, but been a fantastic colleague. In terms of the ambulance service, when I worked in London at UCH, there was an organisation called London A&E Consultants, which was set up to support the ambulance service.
Were they like a charity?
No, it was just a representative from each of the sectors of London from emergency departments to work with the LAS, and I became chair of that group. And as chair, I was also chair of the local ambulance service paramedic steering committee, which every ambulance service had to have under the IHCD regulations.
Right.
So what that meant was signing all the paramedic certificates, and in fact Martin Flaherty, who's now the managing director of the Association of Ambulance Chief Executives, he was the head of training then, and so he did all the work. I just signed the certificates.
But so you went through a lot of pens.
I got through a lot of pens and signed a lot of certificates. Then when I moved to Oxford, I continued in that role because I was initially part-time in Oxford. And when I came back to Charing Cross is when they started advertising medical director roles for ambulance services. So I applied for that and started as medical director for the LAS in 1997.
Wow.
That was initially 2 days a week, but it kind of went from there. And so by 2013 I was working full-time for the ambulance service, still doing occasional shifts at Charing Cross. So then I became chief executive of the LAS in 2015, moved on from the LAS to SECAmb in 2017, did a couple of very brief spells just as interim CEO at SECAmb, and stepped down as medical director at the end of January to pursue a sort of portfolio career, one aspect of which is working for the air ambulance charity of Kent, Surrey, Sussex, which I do 2 days a week as senior medical advisor, which is fab.
Yeah, I bet it is. That's awesome. So this drive to be a doctor or an RAF pilot, was that from a child?
Yes, I always wanted to do medicine, but I like the idea of flying fast jets. But
And now you do both. Well, maybe not.
Maybe not a fast jet, but yeah.
Oh, that's awesome. And then, what was there something in particular that inspired you to do emergency medicine, or was it just that that's kind of something that works for me with family and things like that?
So emergency medicine combines acute medicine, acute trauma, and it's great for somebody with a short attention span.
Oh, there you go. So would you say you've got a short attention span?
Oh yeah.
Oh,
absolutely.
okay, fine.
So most emergency physicians, see it and move on.
That is
that
true.
defines
actually.
like probably a lot of us, doesn't it? Like that attention span.
When they talk about ADHD, which is like an attention deficit problem, they say a lot of sort of pre-hospital people have that as well, don't they?
Or traits of it.
Yeah. But no, actually saying that, I think I've got a short attention span. Look how easy we've just digressed. That's crazy. So, can you tell us a bit more about the role of a medical director then? What it's about, and things like that?
So it's a statutory requirement for foundation trusts and indeed ambulance trusts to have a medical director. Although I think that may change in years to come, and certainly we've seen the first ambulance service in Wales appoint a clinical director who is a consultant paramedic by background, and I think that may well be something that ambulance services move to over the coming years. But essentially the medical director is responsible for the clinical aspects of an ambulance service, so approving the protocols, although mostly the clinical protocols are dictated by the Joint Royal College's Ambulance Liaison Committee. And so we have national guidance now, but also responsible for clinical risks or the clinical aspects of risk, clinical audit, research and medicine. So the medical director is generally the accountable officer for controlled drugs.
Oh, I see.
And what are your thoughts of like the Welsh Ambulance Service, for example, of them passing that role to a paramedic and not a doctor?
So they have a deputy medical director who is a doctor,
Right.
called John Whelan, who's a very very experienced intensive care doctor and anaesthetist, with a hugely experienced in pre-hospital care. And I think that there's a real role for developing the role of paramedics within ambulance services, so that there is a career structure that will see them becoming a director on the board. But paramedicine is still a pretty young career. So first paramedics only in the 1980s. So if you compare that with nursing and with medicine, it's still a very young profession. But I think as the profession develops, we need to find ways of developing paramedics through the 4 pillars that the College of Paramedics espouses, so that they have the opportunity to undertake senior management roles.
I see. So things like when things go sort of dramatically wrong at like a major incident, or and they call in like a lot of people and they just sort of do an investigation and find out what went wrong. Would it be someone like the medical director that would go along and then almost reference all of the policies or the guidelines that they should have been following at the time,
and ultimately be accountable for the actions of everyone?
Yeah.
For the clinical actions, yes, and I think from my experience that played out in the inquest into the London bombings, which happened about 6 years after the event. And I spent about 5 hours in the dock with Dame Heather Hallett explaining the actions of paramedics, particularly around triage and the interventions that were possible on scene.
That must have been an experience.
It was an experience, but I think it was a much more difficult experience for some of the paramedics and other members of the ambulance service who had been involved during the London bombings, because it brought back all that they had gone through, and particularly, for so many of them, but particularly for those involved in the bombing on the Piccadilly train from King's Cross, that was particularly horrendous.
I suppose things like that, these inquests and investigations that go in, the attitude around it is that it's more of a learning process and how can we do things better next time, as opposed to we're going to try and find someone to blame. Is that how you felt in sitting in the docks? It felt like more of an investigation on what we can do better next time, as opposed to we need someone to blame for all the things that went wrong.
Well, because learning culture is only just starting to come in, really, isn't it? Whereas we're going from blame to learning. So I guess back then, was it still blame, or was it,
I think there's an element of that. So in the immediate aftermath of a major incident, everybody is congratulating the emergency services for how well they did. As time goes on, there are often cracks that appear, and people realise that everything didn't go quite according to plan. And so there is certainly a role for going back and seeing what could have been done better. I do a talk on lessons identified in major incidents, not lessons learned from major incidents, because if you look at the lessons, they tend to be the same lessons time after time, particularly around communications. So I think the move to PSERF away from the serious incident investigations is really positive, because you look at the outcome of a lot of serious incidents, it is about who's to blame and establishing the same learning points, but not actually making sure that those learning points are taken forward and that we don't do the same things again, but also that everybody that was involved in that incident has the opportunity to have their say, because so often people who may have been on the periphery of an incident don't get involved, and the people at the centre feel that they were basically to blame in some way, and I think that doesn't help in terms of establishing a really learning and positive culture.
So we all know that the NHS is in a crisis with its identity, the way it delivers care, and many other things. How much influence do a team of directors have on big decisions, or would these decisions come from sort of anyone higher than directors, whether that be government level or like an intermediary between?
I guess a lot of policy is dictated by NHS England, and it is the job of the board of directors to ensure that the organisation that they're running hits those targets and follows the guidance from the centre. So boards don't have that much flexibility. They have the opportunity to decide where they're going to spend their funds and how to prioritise. But essentially the NHS sets its direction every year, and at the moment getting waiting lists down is an absolutely vital part of that, as is improving ambulance response times and improving A&E waiting times, which are currently still fairly horrendous. From the point of view of an ambulance service, I think COVID really brought out the importance of the risk that ambulance services run when they have a lot of patients in the community that we can't get to because there are vehicles stacking outside hospitals. Now, in both London and South East Coast, which are the areas that I'm familiar with, we have had some problematic hospitals, but not as bad as some other areas of the country where they have pretty much the whole fleet stuck outside an ED.
Yeah, you hear stories of ambulances queuing sort of like 10 hours plus outside
Yeah, when
hospital.
I worked down events last summer, I was speaking to crews from South West ambulance service, and they were saying they queue for like shift after shift. So like one crew told me they would go out, sign on, do their first job, convey that patient to hospital. They would sit at hospital for 12 hours, go home, hand over to another crew at the hospital, come back in the next morning and take over from that same crew with that same patient. And I'm just like, that's absolutely... And then it makes you realise how fortunate's like the wrong word, because we're still stacking and queuing, but how fortunate we are in comparison to...
We don't have anything like the same delays.
No.
Having said that, in some places in the country, urgent care has really stepped up to the plate there, because I'll give you an example from the southwest, because we've got a little place down in Cornwall, and my next door neighbour, who's 88, came and knocked on my door one Saturday afternoon, which was really unusual because he's terrified of my dogs.
Yeah.
And he said, my heart's going slow. And I said, yes. And he said, 48. So checked his pulse, 48. So he didn't have any chest pain. He hadn't got any edema. He wasn't breathless, but he did feel a bit dizzy. And he wasn't quite sure when that started. But the fact that he'd come across on that day meant that something must have changed.
Of course, yeah.
So working diagnosis, complete heart block. What are you going to do with him? Now, if any of my crews had said, well, I'm going to leave him at home, I'd have gone, really? So we thought, well,
Here's your P45.
Absolutely. So I had a conversation with his wife and his daughter next door, and it was by this stage 5:30, Saturday afternoon, so GP wasn't going to be open, so we thought, well, let's see if the system works. We rang 111, and they got, somebody will ring you back. Right. Somebody did ring them back, and they said, can you come to Bodmin Urgent Treatment Centre at 7:40 this evening? So they did, and he was seen there. They did an ECG. They discharged him home on the proviso that his daughter stayed overnight in case he felt faint or unwell, and he was told to go to Treliske Hospital to the AMU the next morning early, and he would be admitted. So they had a bed arranged for him on the AMU. He was admitted there. He had a pacemaker fitted on the Tuesday and was discharged home from rehab.
Oh wow!
Look at that.
And that's the system working, isn't
and
it?
that
That's
really
it.
is how the system
Yeah.
can work.
Yeah.
So even though they have problems with ambulance turnarounds, some of the aspects of urgent care, and that was a really good example, which I've not seen duplicated either in London, and certainly the local practice that I attend weren't able to do that, or when working in SECAmb. But it is a really shining example of how the system can work.
Oh yeah, and I think we always hear the bad stories more than the good stories.
Oh yeah, of
right?
course you do, and it's that thing, isn't it? You know, like you can do a million great things, but it's the one bad thing that people remember you for. You know,
Yeah.
and that's it, sadly.
So going back to the board of sort of directors for an ambulance trust, it seems like there are quite a few limitations to what you can put forward compared to what NHS England want you to do. But what we see as well is that sometimes there's a mix of clinical and non-clinical people on the board of directors. Sometimes there's no one who's clinical apart from the medical director or something like that. But what's your thoughts on having a mix, or do you think there should be more clinical people, less clinical people, to sort of like make a better decision-making process?
I think a mix is important. I mean, you need the specialties like a director of finance, and that's not going to be a clinical role. You need a director of HR, and that's unlikely to be a clinical role. But I think the role of the medical director and either the paramedic or nursing director is really important. And in an ambulance service, the director of ops comes from a clinical background, although clearly they are there as a director of ops, not as a practicing paramedic.
Of course, yeah. And do you, you've worked for a couple of trusts, and do you find that they all generally work the same, or do they run completely differently?
The structure is very similar in that you have a board of directors and you have the non-executive directors whose job it is in a foundation trust to hold the board to account. They also have a council of governors who hold the non-execs to an account. That's different in an NHS trust.
Fine.
But essentially the structure is the same, that you have a chair, you have a group of non-execs, some of whom will be clinical, and a group of executive directors.
I see. And then I suppose you've got to look at the demographic and geography of the trust, right? So they're going to run slightly different depending on things like that. They're going to have to design the way that I don't know, the amount of drugs that a paramedic can give, for example. I know that in like sort of city centre trusts, they generally give less medications than a trust that might have to travel 2 hours to their local cath lab. Do you know what I mean? Whereas, you know, where I work, your local cath lab is generally within 20 minutes driving, so you're not going to be giving all different things. It's mostly just GTN and aspirin for an MI, for example.
I think most ambulance services have a standardised drug regime. They carry it up to a certain maximum of control drugs. The control drugs are the same. So
Yeah.
I think it's pretty standardised now. I mean, I take your point, and certainly when we had a shortage of some of the thrombolytic drugs, or there were difficulties getting to the cath lab, we had to adjust our policies a bit. But by and large, ambulance services are pretty standardised.
Oh, okay. Oh, well, that's kind of good to know in a way, I suppose.
There is
because-
some difference. London have just been given, is it midazolam?
Yeah.
Yeah, whereas like we still don't have midazolam over in...
CCPs have midazolam.
CCPs do, yeah, but not paramedics
Yeah.
themselves, but yeah.
So, did you have any ideas that you put forward as a medical director or CEO that didn't get implemented?
So I think there will always be financial constraints, and that's usually the reason that if you've got something that you want to achieve, that doesn't happen. And I think one of the examples is implementing a different medicines distribution centre, because if you have a centre which is perhaps not up to standard, or you need to make significant alterations to it to bring it up to standard, you need to know whether the money is there for that, because that might not be the trust's priority for that year.
That kind of makes sense, really. And I suppose you can have all of these good ideas, but then when you work out how much they cost, it's just it turns the tables completely, doesn't it?
But it's also about explaining to people, if you know, paramedics or all our staff come up with some really good ideas, and it's important that they are listened to. And if you can't implement them, why you can't implement them? Is it because it's not that great an idea, or it's just not one of our priorities for the moment? And we just don't have the funding at the moment. But thank you for the thought that you've put into putting that idea forward.
It's funny, we're going to run through some ideas that we've had
Yeah.
from our listeners, and I imagine that the reason why things like that haven't been implemented is because
It's cost
probably 'cause of
probably,
money.
yeah, which is just... But it's a shame, isn't it? Because there are some really good ideas out there, and yeah, the fact that cost is... When it comes to people's health, you just think cost shouldn't be an issue. Do you know what I mean? It should just be fine. We'll find the money, like, not us, but the government or whatever, and you know, just gets rolled out regardless, like...
Yeah, I mean, there's different ways of looking at it. We
Yeah.
could literally go right down a rabbit hole of talking about how government should spend its money.
Oh yeah, of course you should.
Maybe
Yeah,
another
that's
podcast.
not for us.
Well, Rishi Sunak is coming on next week, so yeah, let's speak to him.
God, could you imagine? In your time as a medical director and CEO, were there any plans in progress that would have completely changed the ethos of the ambulance service, but didn't go through, or you didn't have time to complete or see through, or?
I think that's probably more around implementing a CQC, implementing the recommendation of a CQC report, because if you get a really poor CQC report, and I've been in an ambulance service when that's happened on 2 different occasions, then that becomes pretty much the priority, and so whatever you were intending to do before that may have to change. I think one of the important lessons that I learnt was the importance of listening to staff and being seen to listen to staff. I know in London we had I think we're really successful chief executive roadshows when Peter Bradley, who was the chief executive for many years up until 2012, up until the end of the Olympics, used to do pretty much every year to 18 months going around all the main stations and giving a presentation and listening to staff, and I had the opportunity to join him on those, and that was a really good opportunity to listen to staff and also to explain what we were doing, what had changed. So and I think the current management in the LAS has done a lot to listen to staff, and I know that that's something that's happening in SECAmb at the moment.
So, are there any challenges that you face as a medical director or CEO that operational staff are just not aware of?
I think they probably aren't aware of the level of risk that a medical director, and in fact the board, carries. So I can remember one particular evening being in the control room when we were stacking well over 300 calls. Now, I know that through COVID a number of ambulance services were in that position, but when you think of 300 people out there that you cannot get to, and I don't think that staff on the road have any concept of the degree of risk that you are carrying and that you are aware of, and the feeling of powerlessness. You know, you just can't, you can go and get on the phones, but you may be able to speak to 5 or 6 people out of 300, and just trying to manage that risk can be quite difficult.
It is, yeah, and I remember during COVID, we got a message down on our MDT that said, can you blue light every single patient to the hospital? Because they were holding so many calls. They said, can you blue light every single person to the hospital? And then whether they're a pre-alert or not, you either decide whether you want to call the hospital or not. But to save time, can you blue light it to the hospital? And everyone was up in arms about it. Oh, my driving licence, this, that and the other. And I was thinking, well, if this has come down from someone higher up, if you end up crashing and, you know, it's not technically an emergency, I'm sure that it's not going to come back on you. No. So I just followed those rules, and I don't think that the ambulance service is that corrupt that they would make you do something that you would end up getting the blame for. So.
Whoever made that decision, and I made that decision one evening in London.
Yeah.
I think most of the staff actually refused to do it on that occasion, but that's the level of risk that I would have been carrying.
Yeah, that's it. And it's the same as like as clinicians, and you, Fiona, as a clinician, we all take risks depending on certain things that we need to do, and also leaving people at home. That's a big risk.
Oh, huge risk, yeah.
And you know, but we have to weigh up the risk. And I suppose as a really high level manager, your risk is every patient in the trust, where our risk is just to ourselves and our patient.
And one patient at a time.
That's it. And I think that's really difficult to get our head around. Is that really the choices that you're making is completely different to the choices that we're making on a one-to-one basis.
I'd say we're ignorant to it, aren't we, to an extent, because we don't think about that. What we're thinking about selfishly at the time is our one patient, like you say.
Yeah.
But nor should you have to. It's not your job. It is the job of the board of directors to take that level of risk and to manage it.
Yeah. No, 100%. Yeah. So moving on, what advice would you give to someone who is a paramedic? They've got no degrees in business management or finance or anything like that, but they're passionate about positive change and would love to step into a role in senior management.
I guess in a foundation trust, there's the opportunity to become a member of the Board of Governors, and that is an opportunity to see how the board works, to see how the Council of Governors can influence change within the ambulance service. It's an opportunity to listen to your colleagues and be the focal point for your colleagues feeding information back to the board. And I think that's a good start. I think in terms of career development, you probably need to decide which route you're going to follow, whether it's going to be a route that whether you're going to go into specialist practice and head down the urgent care or critical care route, whether you're going to specialise in education, whether you're going to specialise in research, whether you're going to start a career in management. I think ambulance services have been slow to identify their potential high flyers and give them exposure to other aspects of the health service, because we tend to see ambulance staff progress up through the ambulance service, often their own ambulance service, less now perhaps than before, but not taking the opportunity to go out and work in an acute trust or in an ICS to see how the wider health service works, and then take that information back into the ambulance service.
That's true, and because then you're still sort of in the circle of the ambulance service, and you don't really think outside the box as much as what you might need to as a manager. I read something called the Peter Principle. I don't know if you've heard of it, and it's just a theory that everyone gets promoted to their level of incompetence.
Yes.
And I sometimes, when you see any manager, it can be as like a team leader to a high level manager, you think to yourself, how on earth did they get to that position? But the idea of the Peter Principle is that they were really good at their job before. So say, for example, I could be a really good paramedic, but then it doesn't necessarily mean that I'll be a good team leader. But because I am a good paramedic, I get then promoted to be a team leader, and then that's basically being promoted to my level of incompetence, because then I can't move on from there. But if you're good at being a team leader, you then become a group manager. Do you know what I mean? So so you're always going to get promoted. Well, not always, but that's why people sort of fall through the net, don't they? So you spent a large part of your career working in the ambulance service. You pioneered change, and you represented the ambulance service at some really difficult times. You're talking about during the London bombings and things like that, and I'm sure there's been other times as well. What are you most proud of in your career within the ambulance service?
Well, actually, it's not so much within the ambulance service as setting up the London Trauma Service.
Oh, you set up that?
Yeah.
Oh, wow.
So Healthcare for London was set up in sort of 2007, 2008, and one of the projects was introducing a major trauma service in London as a sort of pilot for the major trauma service that's been rolled out across the rest of the country. So we went live in 2009. At that stage we accredited 3 major trauma centres, the Royal London, King's and
St George's.
But it was clear that for London they really needed, both in terms of volume and just geographical coverage, they probably needed 4 major trauma centres, and St Mary's were very keen to become a major trauma centre. They had quite a lot of obstacles to overcome to achieve that, but they did, and London went live, has 4 major trauma centres, and management of major trauma patients in London is, I think, outstanding.
Yeah, because I recently did a course that we're made to do. What they call them, like key skills.
Yeah, like manager training. Yeah.
And we talked a bit about trauma, and they said that the amount of people who survive just traumatic incidents just spiked, didn't it, when the trauma network was introduced? And
it all started with a report called Trauma Who Cares, which was published in I think 2007, which was the first time that the government really took notice of the staggering facts around trauma, which is just by taking somebody to the nearest hospital did not give them the care that they needed, and that by specialising care in centres that had all the specialties, it would improve the care of patients, and also ensuring that patients got treated by senior clinicians. So the importance of having a consultant team leader leading the trauma team, which now is standard practice.
Well, yeah, that's it. And sometimes I've taken, people who don't necessarily meet the criteria for a major trauma centre, you take them to your local trauma hospital, and even then some of the doctors sort of freak out, and you just expect just a couple of doctors maybe, but they get a whole team of people in, and you're going, oh, hang on, they've only just fractured, dislocated their ankle or something like that. It's hilarious. So when you were training as a doctor, it was, and it kind of still is in some ways, a very male-dominated field. And you even spoke about being an RAF pilot. It was very difficult to do as a female, which is why you went into medicine, or not why you went, but
Probably wouldn't have been suitable to be an RAF pilot.
Yeah. So when you started out as a med student, did you feel like you had to prove yourself or almost work harder because you were female?
Yeah, I guess so. I mean, certainly when I was at school, and we had careers meetings, and you were asked what you wanted to do. It was, well, if you're a female, why don't you go and be a nurse? Not that it isn't a fantastic career, but I wanted to do medicine.
Yeah.
And when I was at medical school, I think a lot of people, and it wasn't necessarily because you were female, a lot of people ended up in medical school with an imposter syndrome. So yes, I worked really hard. Would I do it the same now? No, I wouldn't. I would have a much better time at medical school and not work so hard. And because people who qualified at the same time as me and had a much more social time as medical students, hadn't worked anything like as hard, were as good doctors, if not better. So everybody within 6 months had picked up all the knowledge they needed.
Yeah, and it's crazy because my granddad, even sort of maybe 5 years ago, he said, "Oh, isn't it crazy that there's so many women doctors now?" And I was like, not really. But then he's grown up in a completely different era to what I have. And
you
back
get that
then,
on the ambulance, don't you, with like elder patients? Like they refer to you with a female crewmate, like, oh, and who's doing the driving? And you're like, oh, my colleague is. Oh, and she's driving, is she? They let her drive now.
Yeah.
And like, yes, mate. Quite a long time actually. It's wild that you still get that.
yeah.
Well, I think the ambulance service has probably seen even more change than medicine. Certainly at medical school now, it's over 50% who are female, but that's the same in the ambulance service.
Yeah, and even things like, I know people refer to the heart team as like a boys' club and things, but even that's changing. I've done jobs in the last couple of years, and you see a lot more female heart team members, which is good, really.
Yeah, I mean, and like moving on from that, you can walk into, like you said, an emergency department now, and there's a big mix of male to female doctors, and it probably looks massively different to what it looked 30 or 40 years ago. Do you think there's still more work to do on that front, or do you think we've done it, it's there, it's achieved, and there's that equality?
So there's certainly a lot of work to do on the sexual safety of women, and that's been brought out in a couple of reports from the College of Surgeons of England and the College of Surgeons of Edinburgh, who have had reports which have quite graphically described some of the challenges that young female surgeons have had in dealing with older, more powerful male surgeons, and that just has to stop.
Yeah.
Yeah, 100%. I mean, it's awful. And I've seen it before where, there's a younger member of staff, also sort of a junior sort of clinical grade, and you've got an older paramedic who's been in the job a long time. Yeah, maybe 30 years ago you could comment about the way she looks in her uniform or something, but nowadays it's just disgusting.
I mean, it wouldn't have been appropriate back then, but I guess it wouldn't have been challenged back then because culture was different.
That's so true.
But I have to say, I don't think I ever experienced any. I don't think I had any difficulty in progressing my career because I was female. People were always really supportive. I didn't experience any form of issues around that.
Yeah, and what about when you worked on HEMS? I suppose some people look at HEMS team members as sort of like action figures who, sort of strong because they're on a helicopter and things like that. I suppose that was probably quite a male-dominated field as well. How did you find transitioning into HEMS as a woman?
So I worked with HEMS in London as an emeritus doctor. So I never did a full HEMS secondment. I did a sort of truncated sign-off and then predominantly worked on the car on a Friday evening when they ran a Medic 2 shift.
Okay.
So an emeritus doctor and paramedic would run that shift from 6 to 100 hours, which was great. It tended to be at the end of a fairly long week, and it was always, it was generally in the car. It was only for 1 year when they were bringing in extended flying hours that we got to fly. That and covering the Medic 1 shifts every for clinical governance days.
Okay.
So I did limited amount of time on London HEMS, but thoroughly enjoyed it. I think the model of a doctor paramedic crew is an excellent one. It demonstrates real teamwork. There are some tasks that the paramedic is much better at doing, like packaging the patient, and there are some tasks that the doctor will probably have more experience of doing, like putting in art lines and intubating patients. But essentially, it's a team sport.
Yeah. We're actually going to be asking you a hell of a lot of questions about HEMS in a minute. So hold your horses, everyone. To move on now, the ambulance service in the last sort of, well, quite a few years now, we've been sort of transitioning, or not transitioning, but sort of adding on a little bit of scaffolding onto what we do, and that's urgent care. And we've spoken already a little bit about urgent care, but what are your thoughts on the expansion into urgent care?
I think it's a natural progression of paramedic skills, and I think there are two areas where we can be really influential. One is to have urgent care paramedics out on the road to see patients, and some paramedics are already doing that as visiting for GPs, and then there's urgent care paramedics working in the control room, because I think they've got a huge opportunity to identify those patients who can be directed to alternative routes of care rather than necessarily requiring a frontline ambulance.
Yeah.
And that is probably more appropriate for the patient and means that we can save the frontline ambulances for those patients who are more likely to require conveyance.
Yeah, yeah. And also, because I see it also depends on like the type of paramedic that you also want to be, right? So sometimes I've worked with people that, generally they either get referred to their GP or they go to A&E. There's no in between. And then some paramedics, they really sort of like talking to urgent community response teams, they like talking to palliative care teams, they like to, and there's so much out there that some people aren't aware of, and that's mostly down to probably your attitude to your job maybe, and also the amount of CPD that you want to do. But I just find it interesting that we've expanded so much into it that you can have one paramedic that does not much, and then one paramedic that does loads of it, as paramedics, not even urgent care specialists, and I think that's quite good.
Yeah. There should be the same across the board, though, shouldn't it? Everyone should have that same sort of shared ethos and attitude. And
I think a certain amount of that is around communications and whether people have access to those pathways. And are the pathways consistent? Because every now and again a pathway loses its funding and shuts down, or a pathway isn't 24/7.
Yeah.
And the problem that we have in ambulance services is that we're a 24/7 service, and ideally patients who have a problem at 2 a.m. should get the same service that they do at 2 p.m.
Yeah, that's true. And I know, like, we recently speak about the early pregnancy unit referring people there, and they're only open from 9 till 5, and that causes a lot of issues because a lot of people, what I find is, I only really go to these problems at night, and because they might be having some problems during the day at work. Because they're at work, they think, I can deal with it now. But then later on, they get home and they go, I am going to speak to someone about it. And then we're like, if you called earlier, we could have taken you there, but now you're going to have to wait in A&E for 6 hours. But yeah,
and that is putting more strain on A&E because we know that's not the appropriate care pathway.
Yeah.
But ultimately, you're sort of left with it's too risky if I leave them at home without that onward care at this hour of night versus,
there must be some way that those patients who need to be referred into a service that opens at 9 o'clock in the morning, that referral can be made at 9 o'clock in the morning, and they can be told a referral has been made. You need to contact, for example, the early pregnancy unit at 9:30, and they will tell you when you have a slot.
Yeah, that's so true, and I know some people do that. I know the other day I referred someone to the palliative care team at about 8 o'clock at night, and they said, look, and he was actually okay, he didn't need anyone to see him, but I just thought, he hasn't got any care going forwards, no one's actually coming to visit him, but do you mind giving him a call in the morning or something? And they said, yeah, we'll send a message to the team in the morning. So it does get done, but yeah, like you say, that's just one
and
place.
are you confident that is going to happen?
That's true.
I think that's the other thing that paramedics are always a bit worried that if the referral doesn't go through, will it be because it was on their watch, or are they going to be held responsible? There is something of joining up the service so that those referrals will go through.
Yeah.
And the patient will get a better standard of care.
Yeah, and because paramedics, well, in fact, the ambulance service as a whole, I think, is very risk averse, and rightly so. But I feel like some people live in a culture of make sure, if you're leaving someone at home, make sure you refer them because you need to put someone between you and the coroner. And that I've heard that statement so many times. I hate doing that. I hate calling the GP just to say, are you happy for me to leave them at home? And it's like, no, I'm a clinician, I should be able to make those decisions. What are your thoughts on referring to the GP just to pass the buck, really?
So I think I would come back on something you said, which is the ambulance service is really risk averse. I don't think that's necessarily the case. Okay. There are few situations when a qualified but unregistered clinician can make a decision to leave somebody at home without discussing it with anybody else. So ambulance clinicians have an enormous amount of autonomy, But you're right, leaving somebody at home is probably the riskiest decision that you make. And I think most ambulance services have put in place a phone a friend setup, so that you don't necessarily need to phone the GP, because you won't get the GP mostly out of hours. But if you have a clinician that you can speak to, and I think the opportunity to use video streaming is actually quite helpful, because if you are, for example, a paramedic practitioner who gets a referral from one of your team to say, I've been to see a patient, I think they can safely be left at home, can I just tell you about them? The information that paramedic practitioner has got or is given is only as good as the referrer on scene. But with the advent of video streaming, you can actually interact with the patient and just check that you are happy as the paramedic practitioner to take the risk of that patient staying at home, and any additional questions that you want to ask.
Yeah, that's so true.
I mean, I'd say, like, where you said you think it's like we're autonomous, I get that, but I always call, like, you know, as an NQP, as previously, you know, the policies are cool, but even like after that period, I think you're just covering yourself, because I know, like, a paramedic practitioner has got a wider scope and knowledge than me because they've done their advanced practice, and maybe they're going to pick up something that I've missed for this patient. I might think in my scope, I'm happy, you know, there's nothing there that I'm missing or that I'm risking, and actually just takes a phone call to sort of run through these symptoms, run through what I found, and they go, oh, have you thought about A, B and C? And I'm like, oh, do you know, I didn't actually, that's a really good shout. And then you've avoided that
that is true.
You don't know what you don't know.
Yeah,
that's true. And also, I mean, I'm a big advocate for shared decision making. I'm not saying that I just go along and just leave everyone at home without speaking to them. God, I'm not like that.
I've worked with you.
Oh, perfect.
Not joking.
Don't look at my paperwork, Fiona.
She's going to go away from this podcast and just Tommy's going to get a call from someone like, hey, Tommy, you don't have to come back into work, mate. So we've said that we've heard paramedics across the board sort of say that they wish they could administer or leave at home antibiotics or other sort of simple medications for infections to save going through the GP. Do you think this would be something that would benefit the strain on healthcare, or do you feel, again, this would be too risky to give a bunch of paramedics a set of medicines, or even the right to prescribe if they did their prescribing qualification but didn't have an advanced practice qualification on top of that?
So becoming a prescriber is quite a prolonged course, and requires a level of supervision from a doctor, which most ambulance services are not able to implement. It's much easier to do in general practice. I certainly agree that broadening the availability of antibiotics would assist patients, but I think that this is currently within the role of urgent care paramedics. So those paramedics who have done the advanced practice, I think that's entirely safe, and it's something that we've seen rolled out, so that patients with a chest infection, patients with a urinary tract infection, with soft tissue infections can be treated safely with antibiotics. And I think that, you know, going forward, as more junior paramedics get exposed to those conditions and the prescribing skills, that will probably roll out. But I think it's a sort of stepwise procedure. Let's make sure that urgent care paramedics have that, and perhaps extend the number of antibiotics and conditions that they can treat before taking it to the paramedics who haven't done the urgent care qualifications.
That is true, and also I suppose it'd probably be better to have more urgent care specialists doing those things who paramedics can then call, as opposed to saying to paramedics, oh, here you go, here's a range of antibiotics that you can give.
I think the issue we find, though, is that unfortunately what happens is we train these urgent care paramedics internally, and they do, you know, the university degree and such, but then we don't retain them, and we lose them to primary care or other healthcare settings, and then we're back to square one, where we're just, you know, we're stuck for having an urgent care paramedic on every shift, you know, where we don't have it anymore.
So there's probably a role for portfolio careers going forward. So I think that some services have been quite successful in retaining more urgent care paramedics if they allow them to work part-time. And I think the idea that you're offered a job in a GP surgery and you've got to decide whether to stay with the ambulance service or go into general practice, if you have the option to do both, I think a lot of people would be quite happy to do that. I guess the logistical difficulties are that the GPs tend to work 8 to 6, and ambulance services have to cover a 24-hour shift. So if everybody wants to do working for a GP during daylight hours, how do you cover your nighttime shifts? But I think offering greater flexibility to urgent care paramedics would probably increase the retention. But I think we're all aware of the difficulty in retaining paramedics because back in the day when you became a paramedic, you would stay as a paramedic probably in that ambulance service till the end of your career. Now you have so many more opportunities, and that's great. So I think ambulance services need to be more flexible in the way they employ paramedics.
Yeah, that's true. And, you know, I've seen, like, you know, we've had students before and we've gone, oh, so when you qualify, what do you want to sort of go into, or where do you want to go? And it's almost like you're asking them their way out of the ambulance service before they even started. It's crazy. And going back to the antibiotic situation with paramedics, and I rung up a GP once. I thought this lady had a urine infection, and I rung up the GP and I said, oh, can you just prescribe her some nitrofurantoin or something? And he went, oh yeah, let me have a look. And he went, oh, actually, she's already had a course of nitrofurantoin. And we also, I think he said something like we need to check her kidney function before we give her some more, or change the antibiotic or something. And as, you know, I suppose on the ambulance, it's difficult sometimes for us to gain that whole history to correctly give that right medication. If we're just chucking antibiotics at everyone, that's pretty dangerous, I suppose, isn't it? So maybe it is better to keep it just to the urgent care specialists.
And we also need to think of the antimicrobial policy in the area, because certainly in South East Coast we liaise with a microbiologist who will tell us the most appropriate antibiotics for that region, because it's not always the same.
I didn't know. I wasn't aware of that.
No,
that's
I
crazy.
That's
I didn't realise they do things like that. I'm aware of, like, you know, they track like flus and stuff, don't they, in areas?
Yeah.
But yeah, I didn't realise that.
They also track the sensitivities of the organisms that we're prescribing for. So
wow, that's pretty impressive. I didn't realise that.
Pretty cool.
Right. So we've spoken a bit about antibiotics. What do you think about cocodamol? Because a lot of ambulance services, we have paracetamol and then it jumps straight to morphine, doesn't it? And we go to a lot of things like non-traumatic back pain, and we end up calling up the GP saying, oh, can you prescribe some cocodamol? I know they can buy that over the counter, but you know, there's older people that might struggle to get out of the house to go and buy it, for example. What are your thoughts on adding something like codeine to our scope of practice?
So we've added that to the urgent care paramedic practitioners, and that's quite successful. But certainly one of the issues we had some years ago was that codeine was not being treated as a controlled substance.
Okay.
And it is. So just having loose tablets in your bag with no accountability for what you were giving to who is just not acceptable. So it needs to be carefully regulated. But certainly codeine is a useful drug in people with non-traumatic back pain, although some people find that it's so constipating they don't want to take it for very long.
That's true, yeah. Some people are really sensitive to it, aren't they? Sometimes the GP prescribes it and I've gone, oh, have you taken that? And they go, no, I wouldn't take that. I was constipated for ages after. I thought, oh, fair enough. So really, what we've highlighted is that actually what the ambulance service has done really well is adding all of these things to the urgent care specialist's role. So if you feel like that a patient needs some antibiotics or some codeine and you can't get through to the GP, you could speak to the urgent care specialists in your trust and see if they have these drugs available to them, and you might be surprised to hear that they do. I feel like a lot of staff in my trust feel conflicted between the amount of time they spend on scene to the percentage of patients that they refer, and we're told quite a lot, you know, try and keep your time on scene to a minimum, and they also say, but you know, make sure that you're referring to the appropriate place. And this causes a lot of problems, and I understand that, you know, you can't be a trust who says, yeah, try and refer as many people as you can, or, well, appropriately, of course. But yeah, if you're going to do that, spend as long as you want on scene. You can't say that. There has to be a bracket of some amount of time. So I find that I spend a lot of time waiting on the phone to speak to a GP or any other alternative care pathway. Do you think, and this is my idea, and I don't have any experience in the logistical management of large organisations or anything like that, but if there were more doctors in EOC, for example, geriatricians, paediatricians, psychiatrists, and they specialise in all of the things that we most commonly see, if we have them on hand to speak to in EOC, do you think that is a good idea? Or again, does it just come down to cost?
I don't think they need to be in EOC. I think that and we've seen this in a number of trusts who make their specialists available for paramedics to talk to. So that, for example, you can speak to a care of the elderly physician who specialises in frailty to discuss a patient with them, to decide what the best management for that patient is. Because we know that taking older people into hospital leads to them being deconditioned. If they can be safely managed at home, and whatever care they need at home, then that's going to be better for them. And I think the urgent ward, the virtual ward setup has got some potential benefits there, but putting somebody into a virtual ward, I mean, the whole thing about being in a virtual ward is you should be getting the same standard of care as if you were in an actual ward.
Yeah.
So virtual wards do need people to actually be able to go and see these patients. It's not just a question of putting them in a virtual ward and forgetting about them. Who is actually going to provide the care that they're there? But certainly a number of trusts are looking to provide those pathways so that you can, for example, have a direct referral into the fracture clinic and book people a fracture clinic appointment if they have an undisplaced fracture. Or that can often be done through the minor injuries centre, because I can't often tell if it's undisplaced because you haven't got X-ray on the road.
Yeah.
So you may need an X-ray first. But direct pathways that are available to your urgent care practitioners.
Yeah, no, that's true.
And paramedics, so broadening those to paramedics.
Yeah. So, coming to the end, talking about urgent care, what would you like to see for the ambulance service in urgent care going forward?
I guess greater flexibility in employing paramedic practitioners, so that it's not an either or, general practice or the ambulance service. It's a role which spans both areas, and I think that the experience that paramedic practitioners get working for a GP is absolutely invaluable. The skills and the knowledge that they would bring back to the ambulance service would be enormous. So giving them the opportunity to work in both environments, I think, would be really beneficial.
Yeah, because we have something similar in my trust, which is rolling out, and it doesn't always work because of demands and things like that. But the paramedics, they go off and they work in a what is it called? It's like a group of GP surgeries, and they come back for 6 weeks and they go and do that for 6 weeks and they chop and change. And the knowledge that they come out with, and they go, oh yeah, if we call the GP for that, they'll want us to take them here because of this certain thing. And I'm like, oh, that's really interesting.
It's pretty good for retention as well, because you're getting that variation. You're probably not getting as burnt out as much by.
It's good for job satisfaction.
Yeah,
it's good for
massively.
the patients. It's good for individuals' job satisfaction.
Yeah.
And it means that you're developing your career the whole time.
Yeah.
I think it's so important. So when I do event medicine, I get to work with doctors from a whole range, from consultant anaesthetists down to emergency medicine consultants and so on, and I love it because you're there and you're learning from them, and they have so much to teach you, and we don't get that in the ambulance service because we don't have time for it, because demand is so high and all that sort of stuff, and it's such a shame, because we could be such better clinicians if we had that time and that chance to go and spend with more experienced doctors, nurses, anyone. It's just so beneficial. It's one of the reasons I do that.
Yeah, 100%.
Good for job satisfaction. I think you were talking about job cycle time, and I think there's still a strong belief in the ambulance service that every job takes as long as it takes.
Yeah.
And that's reasonable, but I've seen some patients get an absolutely platinum service, where a silver service would be perfectly adequate. So do you need to make the patient tea and toast 3 times, clear their fridge, vacuum their sitting room, do everything for them, because that isn't actually your job. Your job is to clear the patients in the stack. And I've had quite a bit of pushback around, well, I come to work to get job satisfaction, and if you're telling me I can't give every patient the platinum service that I would like to, then that ruins my job satisfaction.
Interesting.
But actually, if you gave every patient a really good service, but you got to another couple in a shift, that would benefit more patients.
That is so true, and I think that the attitude that a lot of ambulance people has is that you say something like, don't give a platinum service, give a silver service. To them, that's so black and white, and they go, oh, so you want me to be horrible to my patient, do you? And they can't really understand what a middle ground means, and I totally get that.
But I think the other thing is, it's in our nature to be kind and caring, and I think when that patient says, oh, can you help me with this, or can you help me with, you sort of, yeah, okay, sure, and you do it, don't you? And that's just the way we are, I think.
The thing is, if a old lady who lives by herself, who's bedbound, says, oh, do you mind if I have a cup of tea? Then yeah, you probably could make her a cup of tea. It takes 2 minutes, right? But I think that what a lot of people don't understand, and I'm talking about operational staff, is that making that person a cup of tea doesn't then mean that you have to then offer a cup of tea to every single patient. And, you know, like you say, oh, yeah, oh, have you had breakfast this morning? Oh, I'll make you some toast, even though your carer is going to come in about half an hour. And I think that a lot of people, and I've done this before as well, they try and do things to drag it out. And, you know, I think I don't know what we have to do to stop that from happening. It's a difficult one, isn't it?
It's having a more global responsibility for the patients that we are looking after as an ambulance service, and that's not just the patient in front of you.
Yeah.
It's all the patients in the stack that we're not able to get to.
Yeah.
And I think that comes back to what we were saying earlier, doesn't it? It's like we think of that one patient we're with, don't we? We don't think of the higher operational demand.
It's funny you say that though, but on this course, the training day that you will have to do every so often, they did talk about that, and they said, look, you know, they gave us a picture of a patient and said, this patient that you're going to take to hospital, what bigger impact is that going to have on all of the other patients around in the area, the patients that also need to go to that hospital? And basically they gave us a job where it would have been easy to take her in. It would have been a bit of a complicated referral or something like that, but really it would have been better to refer her. And a lot of people said, oh, you know, I'll probably just take her in. And then they made you think about the bigger impact on the ambulance service, on the hospitals, and also on the patients that need to receive care from that hospital as well. And that made us think about exactly what you were talking about in terms of like, yeah, you've got a responsibility for the patient that you're seeing at the moment, but you've also got a responsibility for the patients in your trust, because that is going to have a knock-on effect. It's the way you look at it. I think a lot of people go, no, you know, I'm only here for this, for my patient, and that me personally, I think that's the wrong way to look at it. So we're going to move on to something that we've never done before with a guest speaker. So you're going to be the first person, and Sam is going to introduce that to us now.
So the segment that we're going to introduce is just a set of quick-fire questions, just to get to know you a little bit, just a bit more of an insight, and it just breaks up the episode a little bit for us as well. So, what is the last book you read?
Bring Up the Bodies, Hilary Mantel.
What are you optimistic about in medicine right now?
That's not a quick answer.
We can give them a little bit longer for that one. That's okay.
I think getting the junior doctors' pay dispute sorted out, I think that is a real issue at the moment. I think the consultants are hopefully fairly close to an agreement. The junior doctors' issue is not just about money; it's about terms and conditions as well. And the conditions that junior doctors are experiencing currently is really difficult. When I was a junior doctor, we were part of a firm structure. You had a consultant, a senior registrar, you tended to be on a couple of wards, you knew your patients, you knew the nursing staff, and if you didn't get a meal, somebody would get you some toast and some tea and they would look after you. That's not the case anymore. Junior doctors may not get fed, they work pretty horrendous shifts, and they are not appreciated in the same way that they were. And we're seeing junior doctors leave the profession. We're seeing fewer people going into general practice, and primary care is under huge strain. So putting more funding into primary care and improving the working conditions of junior doctors, I think, would improve the lot of junior doctors.
Excellent. What are you most fearful of?
Getting old.
What person has had the biggest influence on your life to date?
I guess my parents, because they encouraged me to go down a career route which wasn't that common at that stage, and they supported me right the way through, and you know, including babysitting and all that sort of stuff.
Oh, and what is one thing you would want more people to know?
I guess that I have 4 kids and 5 grandchildren. In addition to what everybody already knows, which is that I have 2 boxers, because they appear in all my presentations.
Yeah, they might have appeared in this one. I think you can hear, is it Roo?
No, that's Rafi.
Oh, Rafi, the other one's Roo, isn't it? Rafi's snoring and that, so that Sam isn't going to sleep just yet. Anyway, thanks so much for that, Fiona. And yeah, we know a little bit more about you, which is the idea of the quick fire questions. So let's talk about HEMS, which is what ambulance staff are all interested in, and hopefully doctors are as well. Don't know how many doctors we have listening, you never know. So what is it about working on HEMS that you love the most?
I think it's the ability to deliver a high level of clinical care to people who are either very seriously injured or really unwell.
Yeah, and I think that comes across, doesn't it? Because when you see HEMS turn up, it's almost like a oh, that's all right, because you know that they just need something that you can't do, isn't it? And
Yeah, it's that
or
sigh of relief, isn't it?
sometimes it's a surgical procedure or something that you're just going, come on, you know, their blood pressure dropping, they just need something, and and then HEMS turn up, and I think that's really valuable to everyone, and patients, and also us.
I think it's tremendous support to the ambulance service, and the HEMS organisation that I work for at the moment is one which has great camaraderie. It's a really inclusive place to work, and the level of training and support that staff get is fantastic.
Yeah, no, 100%. And you spoke a bit about your inspirations to becoming a doctor in the first place. What inspired you to become a HEMS doctor specifically?
I think the combination of seeing really seriously ill and injured patients and the ability to get them quickly, whether by air or by road, because helicopters are a transport platform. It's being able to identify those patients and to get to them quickly, and that remains a challenge for HEMS organisations, because certainly the organisation I work for now goes to between 6 and 9 patients a day. Identifying those patients in amongst the thousands of calls that go into the control room is a real challenge and a real skill. So it's the dispatchers and the CCPs who identify those needles in a haystack to identify the right patients that we go to.
Yeah, 100%.
We can bring the skills.
And because I've always wondered this, and is HEMS something that's talked about much amongst A&E consultants? Is it something, how we talk amongst paramedics going, what do you want to do in a few years' time? Is it something that they talk about or not really?
So there is a subset of emergency medicine and anaesthetics who specialise in pre-hospital care.
Oh, okay.
So those are the doctors who undertake specialised training in pre-hospital care and undertake the exams offered by the Faculty of Pre-Hospital Care of the Royal College of Surgeons of Edinburgh. But back in the day when London HEMS first started, the London A&E consultants were extremely concerned about the idea that a helicopter would land and essentially take patients who would normally come to them somewhere else. And I can remember some really difficult discussions back in those days. Now it's accepted. It's accepted as part of the major trauma system that we're able to deploy specialist clinicians to those really seriously ill and injured patients. And increasingly, I think the KSS is going to an increasing number of medical patients. So the split now is about 66% trauma, 33% medicine.
Oh, okay.
And some of those medical patients are particularly challenging, and perhaps the area where we can make the biggest difference.
Yeah, no, 100%. And also, I suppose any element of change is going to ruffle some feathers, isn't it? It's like when I first learned that HEMS dispatch pretty much mostly on a HEMS paramedic just looking through the screen going, oh yeah, that seems something like we'll go to, or they receive a call from a crew saying, look, we need HEMS. And I thought, blimey, surely there's a better way of doing that. Like, it's just like you say, it's like finding a needle in a haystack, but it seems to work well. So then once you give people the data or the results, they go, oh, okay, yeah, that does work well, and then they seem a bit more happy about it.
I think the other thing about HEMS is they have the ability to undertake really innovative care. So we've seen that in terms of identifying patients who might be suitable for ECMO. The Reboa patients that we've seen in London, KSS is trialling whole blood. In some really innovative aspects of care.
Yeah.
When you first moved from working in a hospital to inside of a helicopter, was it quite a big shock to the system with the two sort of completely different working environments?
They're not really different working environments. You're using the same set of protocols and skills. The helicopter is the transport platform, although KSS is looking at what additional skills can be undertaken in flight. We have the advantage of having quite a large helicopter because we fly the Leonardo 169, and so there's a bit more space in there and possibly the opportunity to undertake more interventions in flight.
That is true, actually, because when I thought about that, I thought about it being two different working environments. But when you said that it's not, that actually makes sense, because really, if you're dealing with a critically unwell patient, they're on a bed in a cubicle, right? And I suppose
that
really
helicopter is just your cubicle.
The only difference is that it's in a different space. So actually, it's not really two working environments. The only difference, I suppose, is say if you go to something like a motorbike crash in a hospital, that patient's been brought to you on a bed. How did you find getting that patient or treating that patient on the roadside and then getting them into the helicopter or into the ambulance? Was that a big difference, or was it something that didn't really?
It's something that we drill on the whole time.
Oh, okay.
Using paramedics and also using members of the ambulance service coming in and assisting us with the moulages. So we moulage all these things.
Yeah.
And this is getting slick at deciding what interventions you do on scene, what interventions you do when you've got a patient onto the trolley bed, and ideally how you can stabilise the patient before they go into the ambulance or the helicopter. Because you don't want, you're not going to be doing interventions at the moment in either environment. You try and do those before you get them into that environment.
Yeah.
But as I say, we are looking at what additional skills might be undertaken in the aircraft in flight. But essentially, most patients, we do most of what we need to do before we're ready to move off scene.
And with a doctor on board, what responsibilities does the paramedic have within the team?
It's an equal team. So generally the paramedic will be responsible for the packaging of the patient, and with the doctor looking at the scene and having a plan going forward, so it's a joint plan. There will be certain interventions that the doctor will undertake, there will be certain interventions that a paramedic will undertake, and there are certain interventions that the ambulance crews will help us with.
Yeah.
So it's a team sport. There are times when the doctor and paramedic will do role reversal. So they will decide at the beginning of a job that we're going to do role reversal, so the doctor will undertake the paramedic skills and vice versa.
Oh, wow.
And I think that's really healthy because it means that you really understand the slightly different roles that each undertake. But the gone are the days when the paramedic is the doctor's bag carrier. This is a team sport.
Yeah, and I've seen that. I mean, I've never seen like a scenario where the doctor's like shouting orders and the paramedic's just running around them or anything like that. I think it's brilliant. And also, when we're on a job and you know that HEMS are coming and you can hear the helicopter flying over and you're like, right, okay, they're going to land soon. And then people are going, who's going to do the handover? Who wants to hand over to HEMS? And it's like...
These are the things that you don't see. You're like up there, like, meanwhile the crew's there like panicking, like, no, you got this. No, you take it. Like,
yeah. And like my handovers, they're very like... I try and keep them short, but they don't really give all of the information sometimes because you've got so much going on in your mind. You're going, I just say this is what it is. This is what we've done. Over to you, kind of thing. And what do you want us to do, or is there anything else, more information you want to know? But how would you prefer a handover from a crew when you arrive on a job?
So I think the first thing that we do when we get on scene is to try and find out what the crews need us to do. This is not a question of stand back guys, the guys with their underpants outside their trousers have arrived to take over. This is what you need us to do. But a structured handover along the sort of ATMIST or S-bar, just so that you can get the information in a fairly structured way, and then we make a plan, because although the HEMS have come as a team, we are now part of a wider team. So it's a question of, what do you want us to do? What do you think the immediate needs of the patient are? And then we make a plan.
Yeah, I think that makes sense. And I suppose really it goes on the same as if you're doing like a major trauma handover in a hospital. I mean, I tend to always write them down because I know that I'll miss something.
So do I.
Do you think? Yeah, that's it. And I think I've never seen a doctor or even a critical care paramedic just make up the handover. They've always written it down. And I think, why aren't we doing that? I think it's because people are worried that they look like an amateur or something like that. Everyone's so worried about how they look.
Oh, I always write things down, man.
Yeah.
That's what gloves for.
That's it. I just print off a bit of ECG paper and I'm like,
Just
yeah.
like...
That's what a knee board is for.
Yeah.
Oh, so yeah, I love that. Like, I'd love if we had that in just in our normal greens. That would be great.
Yeah, well, pilots have them.
Yeah.
They just write down, things that they hear about the weather or what taxiways they need to use and stuff like that. So, so HEMS, they arrive to do specific things for the patient generally. It's not going to be like, send HEMS to this because they sound sick. There's always going to be something like, there's something that you can add to the situation, surely. But do you advocate, or how much do you advocate ambulance crews getting involved with the care given by HEMS?
Oh, absolutely.
Yeah.
I mean, it's your patient. We come to see what we can do to assist. Now, that may be advanced airway skills. It may be surgical procedures. It may be assisting with the triage decision. if the patient, some of the patients that you will have called us, so we are coming to provide additional skills. So, for example, a patient where you've got ROSC, where you haven't got a CCP on scene, and there'll be additional interventions that we can undertake to stabilise that patient, and then making the decision of what's the best way to get this patient to the most appropriate hospital. Is it going to be quicker to fly them there, or is it going to be quicker for them to go by road? And if we fly them there, does that free up an ambulance, or actually is it going to be just as quick and appropriate for them to go by road?
Yeah, that makes sense. And do the doctors know what skills and what equipment we normally use? Because I didn't assist the doctor, but the HEMS were doing a Reboa on a patient, and he said, "Oh, can you hold this?" And I was like, because I was just standing around going, "Oh, yeah, I'll have a look at that." And then actually, I just did myself in it because the doctor said, "Oh, actually, can you come and help?" And I was like, "Oh, yeah, okay." But then I was holding this thing, and I thought, "Oh, I really hope he doesn't say, 'Can you get me this or get me that?' and I don't know what it is." So, are doctors familiar with what ambulance crews know?
Yes, they should be. I think that's one of the things that they learn when they do the crew course, as to what skills and drugs the ambulance service carry. Many of them will be experienced in that already and will know.
Yeah.
In terms of, can you get me X from that bag, that would probably be not something that a doctor would expect you to know. You won't be expected to know the ins and outs of the bags that we bring to the scene.
Yeah, okay.
We are expected to know in detail what's in each bag.
Yeah, and to be honest, in my experience, HEMS are so prepared for everything that generally whatever they need isn't going to be in a bag. It's already laid out for them, isn't it? So.
Oh yeah. What advice do you have for aspiring paramedics or doctors who want to work on HEMS?
That they need to be, well, certainly for the doctors, they will be on a training programme in either anaesthetics or emergency medicine. They need to look towards getting the diploma in immediate medical care as sort of the entry level criteria. It's worthwhile getting experience with your local HEMS service, so attending clinical governance days, talking to the doctors and paramedics who are working there. If you have the opportunity to progress to become a critical care paramedic, that's often quite helpful, but that's not to say that paramedics who haven't got those skills can't apply to be HEMS flight paramedics. It's a pretty competitive process, and it's pretty hard work. An awful lot of standard operating procedures to learn, and you get tested on those. So I think that is that's the way to look at it. Certainly, we know that in South East Coast Ambulance Service, the critical care paramedic scheme is one of the reasons that people apply to the service.
I've heard paramedics say, "Oh, yeah, I'm going to move to this trust because of their critical care programme and things like that." So
Yes.
In a previous episode, we've spoken to a critical care paramedic, and he spoke about the governance days that HEMS do, and even not governance days, but I suppose governance that critical care paramedics do.
Yes.
Did you want to talk a bit about governance days that HEMS do, and also because I know we can come and watch them, can't we?
Yeah, certainly London HEMS do a monthly governance session, and that is pretty open to anybody to attend. With South East Coast, with AA KSS, we have a number of slots, and you can put your name down for that. And sometimes if we've got a lot of people who are looking to come and attend, we will run a specific day for them. And that's been quite successful, because it's useful to get two-way feedback. So yeah, I think the governance days are really important. It gives individuals the opportunity to see the sorts of jobs that we go to, the way in which we debrief those jobs, and to participate in the moulages.
Yeah. Oh, I see. So people participate in the moulages.
Yeah,
That's awesome. Yeah. So yeah, I hope everyone has now grasped a good concept of Fiona's roles and responsibilities and her passion for HEMS. We're going to move on and talk about the qualities of any pre-hospital clinician, paramedics, technicians, doctors, whoever. I've been on jobs before where the HEMS doctor is doing an RSI or a Reboa, and there are people talking, getting involved, and it makes me wonder how on earth that doctor can think. Have you ever felt like that your bandwidth is stretched and your brain's just had enough, despite being in a time-critical situation? And if so, how did you deal with that?
So I think we all suffer from narrowed bandwidth in difficult situations. I think when you're doing something like an RSI, I think it's quite useful to get everybody around to focus on what we're going to do. So you say, right, everybody, what we're going to do now is to put this patient off to sleep? Can people all just focus on what you're doing and what we're trying to do for this patient? Clearly, if there's anything that you see that is an immediate safety concern, then please say so. But are you all clear about what roles that you're going to do? This is what we're going to do now, and just give everybody an outline of the procedure that you're going to undertake, so that everybody's got the same plan in mind. And I think by doing that, that gives you a little bit of space. The other way of increasing your bandwidth can be to step back. And one thing that we're encouraged to do is to contact the on-call consultant to run through the plan. And that means that you step away from the scene and you have to summarise what you have done for and what you are about to do to this patient, and to summarise your questions. So whether it's a question of, do you think that this patient needs to have more blood? Do you think I need to give the patient Mataran or whatever? And it gives you just that little bit of space and increases your bandwidth, because otherwise everybody's eyes in on the patient and you tend to lose your situational awareness.
That is so true, yeah. And I suppose I read a passage from, it was a consultant in some speciality that deals with things sort of in the time critical situation. I can't remember if it was a HEMS consultant or something, but he sort of said, in any situation, if your bandwidth is going a little bit, then you can, it's fine to step back and just take 10 seconds. And he said, and I don't want to misquote it, but he said something like, even if you've got an airway problem, it's better to take a step back for 3 or 4 seconds and take a deep breath and get back into it than not do that and completely mess up the airway. And which I thought was quite true.
Mm.
And when I've heard people go, come on, we've got an airway problem, and I'm like, hang on, that's the worst thing to be shouting right now, because that's making everyone panic and things like that. And moving on from that, something that I struggle with, and it's something that doesn't happen often, I promise, is when I'm working with someone fairly inexperienced and I want to do something and they disagree with me or want to change the plan in a time critical circumstance. Normally, what I try and do is take on board what they say, listen to them, and either change the plan if it's better or just explain to them why I want to do it my way. But when things need to be done really quickly, have you experienced someone saying to you, oh no, let's do it this way or that way, and then it throws your mind off a little bit? And if so, how did you deal with that?
I think one of the advantages of the HEMS setup is that you're part of a 2-person team, so you can utilise your buddy to help with those decisions.
Yeah.
I mean, clearly there will be situations when you flip into command and control mode, but I think you need to try and restrict that wherever possible, because that does sound like I'm taking over here, and that rather destroys the whole team.
Yeah.
Ethic.
No, 100%. I know that there's people in my area, and they're almost known as like that I'm the paramedic and you're the technician kind of thing.
Mm.
And, it's going to happen wherever we go. You can go and work in a shop, and there's going to be someone who goes, no, I'm the manager and you're the customer assistant. You listen to me.
I need to take responsibility for this decision.
Yeah, that's it. Do you still become nervous about things at work?
Yeah, of course.
Is there anything in particular that causes nervousness, or is it just dependent on the day?
Oh, it's, am I going to be able to perform this skill? Am I going to be able to get the art line in? Am I going to get the tube down all right? Will I get a decent view of the chords? Have I done a comprehensive primary survey? Does the paramedic think I'm behaving like a complete twat today?
Yeah. I'm sure no one ever thinks that.
No, I can't see it.
But I suppose because you hold such a responsible position amongst the team, not just the HEMS team, but also to the ambulance crews. And I think just you as a person, like an influential person in the ambulance service, when they see you come along on HEMS, they might think, oh God, Fiona's here, I better, And you as that person, does that ever cause a nervousness?
Not so much that. I think just be clear that when I'm flying with HEMS now, I'm flying in the third seat, so I'm not the doctor leading on the case in most cases. Sometimes we make the decision that I'm going to do that, but the doctor will supervise me. So I'm like one of the junior members of the team.
Okay.
Right.
But no, I mean, it's been lovely to be able to go out and see crews, because I really miss SECAmb.
Yeah.
And the opportunity to see people working and to work with them is great. I enjoy that.
Yeah.
Do I terrify the life out of them? I don't know. I hope not.
No comment.
Oh no, I think
I think there's an air of nervousness. I think at HEMS in general, there's an air of nervousness. But then I'd say definitely sometimes there's probably, but not in a bad way. I think it's out of a respectable way in the sort of like, whoa, wow, like, you know.
I suppose you want to impress.
Yeah, that's it. You want, it's
Well,
that. Yeah, you want to
that cuts
impress
both,
them.
That cuts both ways.
Yeah, that's it.
You don't want to turn up and screw up.
Well, yeah.
That's it, and I suppose it resonates with me because whenever people talk about you in the crew room or whatever, everyone says how much of a lovely lady you are. Like, as a manager, they're like, she's so down to earth. Like, you can't imagine such a high manager being just so down to earth with staff members. And I suppose that in itself is really nice to know for you. Well, you probably already know that. Yeah.
I hope that I hope people feel that I'm approachable.
100%.
Oh,
I think
yeah.
you are.
To me.
Oh, yeah,
That's
100%.
important.
Yeah.
Mm.
So, I'm sure that you've heard the good, the bad, and the ugly stories of what clinical decisions or behaviours ambulance staff exhibit. If you had a magic wand and instantly all ambulance staff improve in this area, what would it be?
Respect for each other
Yeah.
and being kind, because I think that's where we don't always do what we might.
Yeah, I quite agree. I think we have quite a toxic culture at times, and
That
we've
is so-
experienced that recently, haven't we? So
That's a brilliant
yeah,
answer.
that is, I wasn't expecting that.
I was
It's
expecting.
thrown me.
I was expecting something like paperwork, for example, because I suppose you must have had a lot of experience in
Oh, yeah.
looking at crews' paperworks, and it goes to a coroner's court, and then you think to yourself, God, if only they wrote about this. But actually, respect is so much more important.
Yeah,
than that.
100%.
Especially in some of the cultures that we work
Yes.
in.
Mm.
Yes, it's about making people feel valued,
Yeah.
Mm.
because nobody comes to work to do a bad job.
No.
Yeah.
But sometimes things conspire a bit against you. But kindness and respect to your colleagues and your patients
Yeah. Yeah.
and your managers,
yeah.
because managers deserve respect as well.
They do, yeah, no, 100%. I think it's awful, some of the things, and like we were talking about this earlier, weren't we? And that a lot of, well, most, in fact, all operational staff, we don't know what's going up in the headquarters, and it's so easy to go, oh, why are they doing this? Why are they doing that? When actually we don't have a clue what's going on up there. And I think that also when people feel respected and empowered, they work better. And we had a student, and he had a difficult first year, and he came to us in the second year, and I would never say to a student, oh, you're bad at this or anything like that. I think that's awful. I think that, if anything, I try and say to them, oh, I was really bad, at some point. Still am. No, I'm joking, not really. But like, and my crewmate was really good at sort of just explaining things, and also just telling him what he's really good at, and then saying, oh, but yeah, you can improve on this. And he even turned around and said, I just really appreciate you saying the things that I'm good at, because last year, and his mentor last year said, oh, he's awful, he doesn't have a clue what he's doing. But actually, that's probably because of the way that mentor spoke to him.
Yeah.
Joe, we're so guilty of that though, like taking other people's words for how another member of staff is, and we're like, oh, so one person says like they're bad or they've had a bad experience, and then everyone else listens to that and goes, oh well, and that it already shades and shadows your view of what you now think of that person.
Yeah.
Like, you should always go in with an open mind, no matter what, like, you've heard or haven't heard about that individual, because it might have been they were having a bad day, or the person they were with was having a bad day, and it just sets them up poorly for the rest of their time.
Yeah. And also, like, if you sort of give people a certain level of confidence, they perform better. And so really, by just sort of, well, like you say, disrespecting people...
It's encouraging them rather than rubbishing them.
Yeah, that's it, yeah.
Exactly.
And then people tend to work better.
Yeah, I think, it's a whole separate topic, isn't it? Like culture and change. Was there anything that surprised you about ambulance staff when you made the move from hospital to ambulance?
So that's a long time ago now, and back in those days, it was, we love doctors in their place. And their place is in their hospital, not in the back of my truck.
No.
Nothing that's changed.
Wow.
But yeah.
Oh, wow. That's crazy. So what, a paramedic would say that?
Well,
Oh,
not
wow.
say it, but they'll probably feel it.
Oh, I see, yeah.
So, they would feel that they were the experts in that field, and they are. But there are a number of doctors who are keen to work with the ambulance service to support them, not to take over the care of patients, but actually to join in.
Yeah. When I was fairly new, I did a transfer from one hospital to another, and we had an anaesthetist in the back. And I thought that he's the doctor, he's going to be the guy who knows it all. I'm just going to maybe sit in the front. I don't know. And but I was so surprised at how much he sort of like integrated me with him, and I think he had an ODP with him or whatever. But I was so surprised at how much he integrated me within the team. But yeah, like you say, people, they just sort of bat people off and go, why are you trying to join my side, kind of thing. But yeah, it's a shame. But I think that's a lot better now, right?
I think it's a lot better.
Oh, definitely, yeah. I mean, ultimately, we're all here for the patient, aren't we? And that's what it comes down to.
Yeah.
Right, we are at our last question, or at least our last question from us. We've got a question from listeners. So you're a huge influence to everyone in paramedicine and pre-hospital care, and other big influences have like a legacy or something they're remembered by. Throughout your career, you've had such a big impact on how we run things and how we develop as clinicians and how we are, as paramedics now and pre-hospital staff now. What do you think your legacy will be and how you'll be remembered?
London trauma system will be one thing, and I think the development of the National Ambulance Service Medical Directors Group will probably be another. I didn't start that, but I chaired it for some years, and it's, I think, gone from strength to strength, and it's currently quite a well-respected group of medical directors and is very useful in assisting to set policy and make changes.
I think that's brilliant.
Yeah.
Something to say that you've done something like that, I think that's crazy. I mean, I think something that all that I'll be remembered by is just something stupid I've done. But to say like I've set this up and this has changed hundreds of thousands probably of people's lives and will do in the future, I think that's amazing.
Didn't do it on my own.
Of course,
Quite clear. But it was a very small team. So there's a lady called Tracy Parr who worked with me in the London Trauma Office, and we had a physiotherapist who worked with us, and basically that was about it. But small team, and we were assisted by people like Sir Keith Willett and Sir Keith Porto, who helped us with the accreditation visits, and they were a lot of fun. So it was a great time. It could be quite challenging because some of the hospitals weren't always happy to be inspected.
Yeah.
But I think it did improve patient care.
100%. Yeah. Well, that's what the data
set the precedent in the future for now, for how we work now. You'll be remembered for your 8-episode podcast, Tommy.
Yeah, that's it.
That's
yeah.
it. No,
I'm gonna get sacked.
8 and out, mate.
After this.
I just think. I think we've peaked. That's it. So we'll move on to questions from our listeners. So we put on social media when we have guests coming on, and then people write in and say, "Well, can you ask this question?" So our first question is from James. He asked, "What do you want to know from crews when they're asking to step outside of guidelines?"
I guess why they feel that's necessary and what they've done so far for the patient. So what are the potential advantages to stepping outside the guidelines, and obviously what are the risks?
Yeah, no, that's fair enough.
Yeah.
And also, I mean, the only time that I've heard people stepping outside of guidelines is, certain trusts say, you can't shock in manual mode until a specialist is there, but they either something has happened with the defibrillator and they need to go in manual mode and things like that. I think the JR calc is pretty black and white. I don't think there's many. I mean, you could. It's a bit subjective in terms of grey areas, but I think it's fairly black and white in what we can and can't do, isn't it? So. Yeah,
and around things like PGDs, they are legal instruments,
Yeah.
and so you can't go outside those.
Yeah.
And sometimes you think, well, if we're giving it down to a sort of particular age, if the patient's a couple of years younger or they look a bit bigger, is that reasonable? But if the guidelines, if the PGD says, I don't know, 12 years, then it's 12 years.
Yeah, that makes sense, yeah. So the next question is from Olivia. Shout out Olivia. She's asked, how is poor mental health in emergency personnel being prioritised?
I think it's a very good question, Olivia, and we know that it's a national issue. We've seen a significant increase in people in ambulance services and in particular in control rooms experiencing mental health challenges. I think especially since COVID. I think there is a lot of support around. There is a great deal more awareness now. Ambulance services recognised some years ago that the rates of suicide amongst paramedics were higher than other professions, and so there is a lot more help available. Ambulance services have appointed mental health clinicians who, in addition to providing triage in the control rooms, are also available to advise staff. and to signpost staff. There is, of course, the Blue Light Mind organisation, which provides a great deal of support. So I think it is pretty high on everybody's radar now, and there's a much greater appreciation. I think one thing that we perhaps don't always do is to look at our selection processes to ensure that the people that we bring into the service do have a basic level of resilience, because people come into the ambulance service to help patients, but I think some people feel that may, by helping patients, they may help themselves, and they do need a certain level of resilience before they embark on that, because otherwise they may just find it really stressful and make their own problems worse.
Yeah,
that's
I quite agree.
True.
Yeah,
and because I've seen questions on Facebook groups and things of people saying, "Oh, I really want to be a paramedic, but I get severe anxiety, or I get really bad car sickness if I'm in the back, but I really want to be a paramedic," and it's really difficult to just sort of, I don't know how
It's
to...
a sensible career choice.
Yeah, that's it, yeah. And I think that it's a difficult one to weigh up, because at the same time you want to support these people, but at the same time you don't want to...
You've got to be realistic and manage expectations,
Yes.
I guess.
That's it, yeah. And even I know a lot of ambulance trusts are doing the trim practitioner thing. That's brilliant, and...
Well, we have that. I mean, I think all ambulance services have that.
Yeah, okay, cool.
But also just having somebody who is looking out for you. And I think team leaders are really good at that. If they know that you've gone to a difficult job, then they'll ring you up. I've had calls from CCPs if I've gone to a really difficult job to say, I'm sure you've been to really difficult jobs like this before, but are you okay?
Yeah.
It's reaching out to somebody, which is just on a personal level. It's being kind.
Yeah.
It makes all the difference.
Oh yeah,
massively. So our last question is from a friend of the show, previous guest, critical care paramedic John. So he asks, if you were a healthcare action figure, so they were Mattel were producing a Fionna Moore healthcare action figure, what 2 accessories would you come with?
A stethoscope to remind myself that I am actually a doctor, and a magic wand.
The magic wand, nice.
Look at that. And then that is in a magic wand in itself, because then you could do anything.
There we go. Sorted.
So, we've come to the end of the episode. We just want to say a massive thank you to Fionna for your time, your openness in answering everything that we had. And I think that everyone who's listening is going to be sort of probably forgotten their car journey because of the content that you managed to give us. It's just amazing. So thank you. Is there anything you'd like to add?
No, I just hope it's been interesting, and I'd just like to say how much I have enjoyed working with ambulance services over my career, and I'm delighted that I'm still able to do that in some small way.
100%, and so are we.
Oh yeah, so grateful. Just honoured as well to be sat here talking to you. Thank you so much for your time.
100%. So we hope you enjoyed it. If you aren't aware, we run the Pocket Clinician pocketbooks, and we've got a couple of new products. We've got the ECG pocketbook, and we've got...
Well, it's not new, but we've got the student paramedic pocketbook that looks at history taking, documentation and patient assessment, and then you can get them both as a bundle as well, both available on our website at pocketclinician.co.uk, and don't forget to give our social media channels a follow on Instagram, at Pocket Clinician, at Bullhorns and Sirens.
Yeah, and we've got some brilliant guests lined up in the future, so stay tuned.
Thanks so much for listening. We really hope you enjoyed it. If you want 50% off your first year subscription with CPD Me, head to our website www.pocketclinician.co.uk and you'll see a link on the homepage that leads you to CPD Me. Type in the discount code Bullhorns CPD and claim your 50% off your first year subscription.